Good afternoon. Now we are open the session, renal session for the renal function assessment.
And now Professor Belkis has started the session. I'm going to ask her to give the first presentation.
Good afternoon again. My talk is in the renal function measurement in the area of PRRT, peptide receptor radiolabel therapy. I have no disclosure. In the recent years, theranostics are available in many countries, and then the application of this diagnostic and therapeutic modality is available many centers. Gallium-labeled diagnostics or lutetium-177 or yttrium-90 labeled therapeutics are used for the therapy of mainly two different oncological pathology. The first one is neuroendocrine tumors. The peptide receptor radionuclide therapy is called for this therapy type, and dotatate or Datodog or many others are labeled either for diagnostic radiopharmaceutical or therapeutic radiopharmaceutical. Prostate-specific membrane antigen is labeled again with diagnostic or therapeutic radiopharmaceutical for the imaging and also for the therapy of the prostate cancer in patients with castration-resistant metastatic tumors. Peptide receptor radionuclide therapy is a successful modality. Because of this reason, this therapy modality found its place in many guidelines after the publication of NETTER-1 phase 3 clinical trial. In other studies, the objective response rate was published from 15 to 35%. In NETTER-1 study, lutetium-177 dotatate was used in patients with advanced, progressive, and somatostatin receptor positive mid-gut neuroendocrine tumors. And they reported that the response rate was 18% compared to the 3% in the control group who received the high-dose LAR. And they also found the prolonged progression-free survival compared to the other therapy modalities. And they reported no significant nephrotoxicity. However, it is known that bone marrow suppression is a problem in those patients, and approximately 10% of the patients had the clinically significant myelosuppression following the therapies. Renal function impairment also observed in many studies. Therefore, these two organs are accepted as a dose-limiting organs, bone marrow and kidneys. We have to decrease the dose, not to toxic those organs. Here you can see a PET-CT using the gallium dotatate in a patient with bronchial neuroendocrine tumor here and many metastases in the bone. And this is the therapeutic images after lutetium dotatate therapy, first, second, third, and the fourth cycles of the therapy. There is a very high uptake you can see in the kidneys together with the metastatic area. And at the end of the successful therapy, there is a high uptake again compared to the liver. Here you can see the renal accumulation of the tracer. Renal accumulation is high with PRRT because there is glomerular filtration of this tracer, and tubular reabsorption by the proximal tubule is also responsible for the uptake of the tracer. Tubular reabsorption is mediated by the megalocubulin receptor system. Endocytosis is also responsible, and at the end, approximately 3% of the total activity is accumulated in the kidney to radiate the renal cells. Interstitial retention of the tracer also contribute the radiation dose, and also the presence of the somatostatin receptors in kidney, mainly somatostatin receptor 2A type in glomerulus, and all 5 somatostatin receptors in tubules are responsible for the uptake of the tracer. In this study, it was shown that radiolabeled peptides the tubular reabsorption of these peptides is mediated by the megalin and cubilin transport system in the kidney. Radiation nephropathy is seen because of the high radiation dose to the kidneys. However, the experience came from the external beam radiation therapy. When we look at the histopathological changes in the radiation nephropathy, the main abnormality is the thrombotic microangiopathy and arterial glomerular changes, which is more pronounced compared to the tubular change, and later tubular interstitial fibrosis and atrophy is seen in those patients. There are limited experience about the histopathological changes due to radiation nephropathy with PRRT. However, in the biopsy material of patients with therapy with yttrium-90 show that thrombotic microangiopathy is the main abnormality in the kidney, histopathologic abnormality. It is because of the endothelial cell injury from radiation exposure. When we look at the terminology, radiation nephropathy can be divided into subgroups: acute radiation nephropathy and chronic radiation nephropathy. Acute nephropathy can be seen with higher doses than 25 gray, and it occurs approximately within 6 to 12 months. It can recover spontaneously, or there is a progression to the renal failure during the time. The second one can occur from 1 to 5 years, and the reason is with lower radiation doses, and there is a volume loss of the kidneys and the functional decline. Renal parenchyma has a slow cell turnover rate. Because of this reason, there is a latency period before clinically detectable functional decline. Because of this reason, we have to follow up the patients for longer time to detect and monitor the renal function impairment in PRRT. Again, when we look at the doses or safe doses, the data is collected from the external beam radiation therapy, and 15 to 17 gray with 2 gray fraction is accepted as a safe dose limit in radiation therapy. Experiments show that 23 gray cause renal failure in 5% of the patient in 5 years. On the other hand, the nephrotoxicity is not linearly correlated with the dose. 28 gray cause renal failure 50% of the patient in 5 years. Because of this reason, lower radiation dose should be given to the kidney with fractions. The data from the EBRT is extrapolated for radionuclide therapy. However, there is a big difference in the radiation type of these two modalities. In the radiation therapy, the radiation exposure is homogeneous with a high dose rate, approximately up to 10 gray per minute, and it is given in the fractions. However, in radionuclide therapy, there is a heterogeneous distribution of the tracer within the kidney. Because of this reason, absorbed dose is heterogeneous in the kidney, and there is a slower radiation exposure rate, lower than 3 milligray per minute, and it is variable within the time, and there is an exponential decline with effective half-life of the tracer. For successful therapy, we have to give the highest dose to the patients, but we have to spare the function of the kidney and also bone marrow. Therefore, there should be a balance between the therapy success and the nephrotoxicity. As many cycles as possible within the reasonable limits for the risk organ should be given to the patient. However, in many centers, there are fixed doses, and there is no difference between the different kind of patients or between the patients with different kind of risk factors. From the studies, renal absorbed dose change between 0.55 to 17 milligram per megabecquerel. There's another definition of radiation dose in nuclear medicine. It was suggested as a better parameter. It is biological effective dose, and it has been suggested that a higher doses compared to the external beam radiation therapy can be given to the kidney without decreasing the renal function. Effective dose lower than 40 gray was accepted as a safe in patients without any risk factors, but if patient has a risk factors, the threshold should be less than 28 gray. In many papers, there are different neurotoxicity rates because they use different therapy, radiopharmaceutical, different cycles between the therapies, different kind of amino acid solution, but the clinically significant nephrotoxicity vary between 0 to 14%. There are individual risk factors which are important. This is older age, pre-existing renal disease, hypertension, diabetes mellitus, previous nephrotoxic chemotherapy, metastatic lesion close to the renal parenchyma, and single kidney. There are also other risk factors related to the therapy type, choice of radionuclides, lutetium versus yttrium, or cumulative radiation dose to kidneys, renal radiation dose per cycle, activity administered and number of cycle, and time interval between cycle, which is recommended as 6 to 8 weeks. And there is a amino acid solution to protect the kidneys to increase the level of the renal uptake of the tracer. It is also different in different centers. How we can protect the kidney, or how we can decrease the renal uptake? We can use positively charged amino acid infusion, because this infusion competitively inhibits the absorption of the tracer from the tubules. Most commonly, lysine and arginine is used together or separately, and approximately 10 gram of protein is given during the therapy, either in 1 liter of solution or 2 liter of solution, sometimes during the 4 hours or sometimes 12 hours. It depends on the centers. In different studies, there's a different numbers, but approximately 9 to 53% decrease has been achieved by using amino acid infusion. In another study, approximately 40% decrease was possible. Another alternative solution is gelofusine. It inhibits megalin-kubulin pathway, and it can be given together with lysine or separately, and it was reported that it decreased the renal uptake by 62% to 70%. Okay, how we can define renal toxicity? When is the renal toxicity? Or how we can assess the renal function impairment in those patients? And can we predict the renal toxicity? These are the important questions in the clinical applications, and we have to know how to measure and follow up those patients in regard to renal function toxicity. There is a general terminology for the definition and grading of the renal toxicity. It is published by National Cancer Institute. It is common terminology criteria for adverse events. It is used in chemotherapy and in other kind of cancer therapies, and in many publications it is used. These criteria are used for PRRT. There is 2 definitions: acute toxicity and chronic toxicity. Acute toxicity is called as a disorder characterized by the acute loss of renal function and is traditionally classified as prerenal, renal, and postrenal. PRRT causes renal toxicity. And chronic toxicity is a disorder characterized by gradual and usually permanent loss of kidney function, resulting in renal failure. Renal toxicity graded from 1 to 5. How we can grade? For the acute kidney injury, creatinine level is used as a reference value. There are 4 grades. In the grade 4 and grade 5, which are accepted as a clinically significant nephrotoxicity, dialysis is needed, and grade 5 is death. In the other grades, there is a creatinine increase up to 2 times above baseline in grade 1, in grade 2 up to 3 times, and in grade 3 more than 3 times, or 4 nanogram per milliliter creatinine levels. In chronic disease, there is another grading system, the same type of grading system, but estimated GFR is used or creatinine clearance is used. This time, using the plasma creatinine levels, GFR is estimated using different formula. Again, grade 4 and grade 5 are the clinically significant toxicities. How we can measure the renal function? We can either use endogenous markers such as creatinine and cystatin C, or we can measure or estimate the GFR, or we can measure the renal function using radionuclides. Creatinine is very easy and practical marker for the renal function. However, there are some limitations of this marker. It is freely filtrated by glomerulars, but its level is affected by the muscle mass, nutritional state, and inflammation. Anti-cancer drugs can alter its correlation between GFR and creatinine clearance. Because of this reason, there is a tubular secretion of this marker, and its sensitivity is insufficient in moderate GFR declines, and its level may be normal up until 60 ml per minute. Cystatin C is not routinely used to evaluate the renal function, but it is sensitive in mild reduction of GFR between 60 to 90 ml. There are some formulas, many formulas actually for the GFR estimation, but commonly known formulas or used formulas are the Cockcroft and Gould formula, modification and diet in renal disease formula, and the chronic kidney disease epidemiology collaboration formula. In PRRT studies, mainly these 2 formulas are used if GFR is estimated. All we know that gold standard for the GFR measurement is inulin clearance. However, it is not available in many centers, and it is expensive. Second important or more accurate method is EDTA, but it is also not available in many countries, including my country, and there is no imaging and no split function. DTP is a cheaper one, and it is possible to find in every country, but there is attenuation by soft tissue, and there is inaccuracy of geometric mean, and there is extracellular localization and variable protein binding. These are the drawbacks of the DTPA for the GFR calculation. When we look at the literature, we can see different numbers of toxicity and different definition of toxicity and different type of therapy, different type of renoprotective amino acid solution use, and because of this reason, it is almost impossible to compare the result. However, when we look at the toxicity with yttrium labeled PRRT, grade 4 and 5 toxicity is reported up to 14%, and grade 1 to 3 toxicity is up to 50%. Actually, in many studies, only grade 4 and 5 toxicity was reported. The lower grade of toxicity is not reported, but it is also possible, because it is also important, because during the time or during the follow-up, these patients may lose their function in the follow-up. Yttrium has a poor beta emission and its T-half is 64 hours. Soft tissue penetration is maximum 11 millimeter and mean 3.9 millimeter. Not only the direct particle effect, but because of crossfire effect, its radiation dose to the kidney is higher compared to lutetium. In a study which GFR is estimated using MRDR formula, in 2 years, GFR decline is approximately 9%, and for a longer follow-up, approximately 8% decline was observed. In another study, again using creatinine levels and estimated GFR levels, 4.5% decline in GFR was reported. In one study, estimated GFR and creatinine levels were compared with the radionuclide methods with chromium EDTA, and they found that estimated GFR overestimated actual GFR values, and it is more pronounced in lower GFR values. Creatinine or creatinine-based GFR estimation may lead to underdiagnosed low-grade toxicity or mild early changes. Because of this reason, radionuclide methods are more accurate compared to the other methods. When they follow up the patients, they found that the GFR or the decline in the GFR progressed during the time from mean value of 12 to 26 in 1 year. This progressive decline is important for patients, and therefore we have to follow up the patients carefully. There are other studies about the nephrotoxicity with yttrium labeled PRRT. Yearly GFR loss was found between 0 to 23%. Another study found that mean decline was 25% within the first year. Another group recommended that low dose protocol is a better because there's a lower nephrotoxicity, 8.4%, compared to the high dose protocol, which is 14%. Another study tried to recommend a critical dose for renal radiation dose, and they described that 37 gray bad is a threshold, should be a threshold for renal radiation dose in patients with PRRT. When we look at the lutetium, it is a little bit different. It has beta and gamma decay. Penetration depth is lower than yttrium. It is 2 millimeter. There is no crossfire effect. The grade 4 and 5 nephrotoxicity was reported up to 9%, and grade 1 to 3 toxicity is also lower than yttrium. It is 26%. In literature, in some studies, radionuclide methods were used. In one study, using 2 sample DTPA, the GFR decline was in yearly decline was 2.1 ml, and lower than 10% of the patients there were 21% decline, and more than 10% decline was observed in 22% of the patients. Another study reported no renal toxicity greater than grade 3, and grade 1 to 2 renal toxicity, where mild toxicity was seen in 25% of the patients. Then there are some studies comparing lutetium and yttrium therapies, and in most of the studies, lutetium was reported as a less nephrotoxic. In a very large series, any toxicity was seen in 25% with lutetium and 33% with yttrium, and Parkinson toxicity or chronic toxicity was seen 13% of the patients with lutetium and 33% of the patients with yttrium. However, there are also other studies with different results. Similar nephrotoxicity rates were also reported. GFR reduction was reported as a 20% with lutetium and 27% with yttrium. Another group reported that significant toxicity was 9.2 with lutetium and 7.9 with yttrium. Actually, those number of cycles, risk factor of the patients are also important, and we cannot directly compare those results. In a practical guidance written by A&M Atomic Energy Commission and the Society of Nuclear Medicine, it was recommended that more precise methods should be used rather than creatinine or creatinine clearance to assess the renal function. GFR measurement can be done using either DTPA or EDTA with chromium, or tubular extraction rate can be measured using MAC3 clearance. And particularly in patients with pre-existing risk factors for long-term nephrotoxicity, it is very important to measure the accurate GFR levels. As a conclusion, grade 4 and 5 nephrotoxicity due to PRRT is relatively low. The lower grades nephrotoxicity is higher. GFR estimation based on creatinine may overestimate the actual GFR levels and underestimate the lower and mild grade toxicity. More accurate GFR measurements with radionuclides are recommended, and renal radiation dose estimation may be helpful to decrease nephrotoxicity. Thank you for your attention.
Thank you, Belkis. We're going to have discussion at the end of the session.
Now we are moving to third talk. It is GFR measurement in children. Dr. Anita Brink will talk on this topic.
Thank you very much for the invitation, and I have no disclosures. It's a bit unfair to speak after him, though. Okay, so as been described previously, inulin is considered the gold standard, but it's difficult to source, it's technically very demanding, and it's therefore not used in routine clinical practice anymore. It was, however, used as the reference tracer in original reference data. Maybe I must just go that way. There are numerous radionuclide methods recommended for use in children. There's the 2-sample method and the 1-sample method, and then there's a lot of people that want to use the camera-based GFR estimates. And we're just going to quickly cover all of these topics. So in pediatrics, the 2-sample GFR measurement using either chromium or DTPA is considered the clinical reference standard. But it's only if careful attention is paid to good quality control of each step of the investigation. And this is just an example out of my own unit where the lady who usually does it was sick, and one of the other technologists did the GFR for us. And if you can see it, the weight of the syringe and needle full, the weight on the one Excel spreadsheet was entered as 3.49, and on the other Excel spreadsheet was entered as 3.44. And just that 0.05 difference in weight made that the GFR changed from being 149 mils per minute per 1.73 meters squared to 59. That's how easy you make a mistake. And the 149 mils per minute was indeed the correct value. So you have to double check the weight and the height of your child when they arrive. The clinicians get the lowest nurse helper to get the patient on a scale when they send you for the referral form, so the weight is inaccurate, the height is inaccurate. So when I do them, I weigh them, I measure them, I make 100% sure that what I'm calculating is the right values. Now, if you use DTPA, the guidelines recommend regular chromatography. Most people in the clinical practice will tell you that the DTPA preparations that we get in the kits are getting more and more stable, so it's becoming less of a problem. And then when you inject, you have to be 100% sure that you're injecting in the right place. So flush with about 10 mils of saline, give your dose, and flush with another 10 or 20 mils of saline. Then meticulous recording of time of injection of blood. As Prof referred just before, we actually have a stopwatch to make sure that if somebody else comes down to draw the bloods, that we have the same watch that we use. And then the patient's fluid balance must be stable during the scan. And what happens is the patients for chemotherapy, platinum-based chemotherapy, comes to the ward. The sister starts the prehydration, and we do the GFR the day before the chemo. So a lot of time, accidentally, the patient starts with prehydration while we are busy with our GFR. So I've ended up making a big laminated sign that goes onto the bed to say, we are busy with a GFR. No drips until this time. Thank you. Okay, so we've got built-in quality control steps. All samples are processed as duplicates, and the British Nuclear Medicine Guidelines say that the values of your duplicates must be close to each other, within 3%. If they're not, sit down and start worrying, because a lot of things can go wrong. First thing is poor mixing of the samples, because you've got your diluted standard, you've got your diluted wash. Have they been properly mixed? So remix your wash, remix your standard, and pipette again. Then poor pipetting techniques. I didn't realize when I took over the department that you have to calibrate your pipettes at least once a year. And they have to be serviced at least once a year. Nobody tells you these things. So you have to do that. And you also have to make sure that your well counter is performing as it should, especially if you're using a multi-well counter. Now, the quality control steps for the pediatric GFRs that we use, might be wrong, granted, is now that I've got my good duplicates, I end up doing my calculation. I've got a volume of distribution, and I've got a T-half that can help me to see if I've done something horribly wrong. And if you think of a child, 70 or 80% of a child is water. Of that, about 35% is extracellular fluid, and about 30% of that 30% of the child's body fluid is easily diffusible. So your chromium or your DTPA will diffuse into that 30% of the body weight, essentially. So the European Association of Nuclear Medicine Guidelines for pediatric GFR say you can accept your GFR if your volume of distribution is between 15 to 40%. Another example out of my own lab, I'm not showing you my highlights, is a child who weighed 13.5 kilograms, and we ended up having a T-half of 61 minutes, which is okay, but a volume of distribution of 7.4 liters, which gives you an idea that the whole dose wasn't injected or we measured the dose incorrectly. So this GFR we actually had to repeat. So then we get to the fact that the two-sample method has a bit of Star Trek happening in there. With the two-sample method, we assume that it's like being beamed up to the Star Trek Enterprise, that when you inject the chromium, it mixes into extracellular fluid like that. And obviously it doesn't happen. It's ignoring the first fast exponential clearance. So we have to correct for that. And by emission of the early blood samples, we are overestimating our GFR by 10 to 20%. So historically, there's been a couple of corrections that we can use to correct for this. There's the Brochner-Mortensen method and the Chandler method. The Brochner-Mortensen method underestimates GFRs over 130 moles per minute, and the Chandler underestimates the low values. Now you might be, why am I worried about the higher values? I do GFR measurements in children with renal failure, with renal disease, and oncology patients. And our oncology patients tend to have high GFRs when they start with their treatment because of that tumor necrosis. So just for the nerds in the room, here's the corrections of Chandler's got a constant, and Brochner-Mortensen is a bit more involved. Luckily, we've got newer correction factors. We've got Fleming's method and the Brochner-Mortensen-Udall method, which add corrections for body surface areas and do not have these problems. So start using these. Come on. Okay. So the slope-intercept method is accurate down to a GFR of 10 to 15 moles per minute per 1.73 meters squared. And that's about it. Now we're going to talk about the normal reference ranges. In 2006, Prof. Pieps and Hum graced the world with a normal reference range for pediatric GFRs. This was calculated from one-sample methods, and as you can see, the GFR steadily increases from birth until 2 years of age, and then we have normal values, so then you can use adult values from there on. Okay, Prof. Ham and Pieps also developed a one-volume sample method for DTPA, And a single blood sample is drawn at 110 to 130 minutes, and they actually say that the blood sample must be taken during that time frame. And then the volume of distribution is estimated and not measured. So you do lose some of your quality control steps that I do like. And this is the calculation that you can use. And the accuracy for the one sample method is accurate up to GFR levels of 30 to 35 moles per minute for 1.73 meters squared. And there might be some errors in this. Okay, then we get to the famous camera-based methods, especially if you work in pediatrics. You're doing your MAG3 renogram, you're doing your DTPA renogram, and you open the processing and that box comes up. You can estimate the GFR. It's so tempting. Okay, so in 1982, Gates described a camera-based method using DTPA. He did it on 31 hospitalized adult patients, and he's compared his camera-based methods with creatinine clearance, 24-hour creatinine clearance method. And now the question is, how accurate is it? Recently, in 2008, I then looked at 150 healthy potential kidney donors. And they used the two-sample GFR as a reference method, and they then used the one-sample method, the Gates method, creatinine clearance, all of these other methods to compare to their reference method. And the Gates method had a bias of 5.7 moles per minute per 1.73 meters squared, with an error of minus 35 to plus 47 moles per minute per 1.73 meters squared. And the creatinine clearance, which was used as the reference method when the GFR method the Gates method was established, had a bias of 15.5 and an error of minus 35 to plus 75 moles per minute per 1.73 meters squared. So another study, which gives us basically the same result, was in Saeed and Saeed in 2015, looked at 96 healthy adult volunteers. And they did the Inui's method and the Gates method. The Inui's method is doing a bit better with a bias of minus 2 moles and an error of 12 moles per minute, where the Gates method had a bias of minus 25 moles per minute, with a root mean square error of 30 moles per minute. So, how's it doing in kidneys? These were all in normal kidneys. So how's it doing in kidneys with impaired renal function? And if you look at this scatter plot, this is the two-sample method compared to the Gates method, and you can see that there's quite a lot of scatter on this plot. And then we finally get to, my clinicians always tell me, oh, but we use creatinine-based estimates. Nita, we don't need to refer the patient to you, we use creatinine-based methods. We use the SWOTS formula. I live in Africa. People in Africa look different than people in Europe and America, where the SWOTS method was developed. We eat different foods. So we actually it's an ongoing research project in my unit, and we were comparing the nomograms, all the different nomograms, compared to the two-sample method using chromium EDTA. And the correlation coefficient is 0.4 to 0.45, with a bias of minus 16 to 29 moles per minute, and a root mean square error of 14 to 34 moles per minute per 1.73 meters squared. So my conclusion, after giving you all of these horrific information, is that the slope-intercept method for children is currently the clinical reference standard. The one-sample method is promising, and I'll be looking at the new British Nuclear Medicine guidelines. Camera-based methods are just not accurate. And if you want to use creatinine-based methods in your unit, you have to validate it, and maybe we need to develop our own nomograms for our populations. Thank you very much.
Thank you very much, Dr. Billing.